And what I want to talk about mostly is what you can expect from us when you have a patient that's at risk for this, or when you get an ultrasound report that suggests that this might be an issue. Some of the kind of misconceptions will touch related to imaging, and then just at the end, just a couple of the things that are controversial in terms of management, but we're not going to talk about the operative management of placenta accreta. So mostly it's MFMs in the room, but how many of you have opened up an abdomen and seen this? How many of you have opened up an abdomen and seen this and not expected it?
It's only in my bad dream.
Well, it is a bad dream. And so that's what the idea of diagnosis is to prevent you from finding this unexpected. You can't do anything about it once it's there, but it is nice to know that it's there, because that very much would change your management. And Michael talked a lot about doing things that are going to affect your management. And so this is one of them, where you would make sure that you've got extra surgical help, that the blood bank is on board, and that it's done in a place with experience. So what I briefly want to do is just talk about the definitions and epidemiology and the risk factors. You guys know most of this. It's just a review. But then talk about the ultrasound findings and the accuracy of the diagnosis is what I want to spend most of the time on. MRI is used frequently. We'll talk about that. And then, as I said, we'll talk about some of the ancillary management controversies, specifically ureteral stents and balloon catheters, iliac balloon catheters. So this isn't a surprise to anyone. The placental trophoblast invades into the myometrium in a placenta accreta. It's classified pathologically by the depth of invasion. The accreta goes through the decidua and attaches to the superficial myometrium. I'll show you a picture of that in a second. The increta actually goes deeper into the muscle, and the percreta goes to and sometimes through the serosa. And commonly, if it does that, the bladder is affected, and less commonly the perimetrium. So this is a nice schematic. This comes from the New England Journal. Here is the placenta all the way across. Here is the decidualized endometrium, and normally the placenta attaches to that, and there's this nice cleavage plane. With the accreta, it comes through that and attaches to the muscle superficially. With the increta, it goes much deeper, and then here the percreta, as you can see, goes down to the serosa in this case, but it actually can go through into adjoining organism or organs. So anything that damages the endometrial-myometrial interface and prevents normal decidualization can lead to an accreta. Everyone's aware that the previa and or a prior cesarean section are the most common by far risk factors. I've also highlighted endometrial ablation because what happens here is these folks, we see them on occasion and they're told that they couldn't get pregnant, and lo and behold they do, and they have an accreta. The majority of the folks that I've seen that have had that and are pregnant do have an accreta, so that creates problems. And contraception for those of you who do these. All of these other things you're familiar with, they're much less commonly associated with it, and they make up only a fraction of the patients who actually have a placenta accreta. How often do we see it? Well, everyone's aware that it has been increasing. It has been following the increase in cesarean sections. It was pretty rare in the 70s, almost 1 in 4 to 5,000. When I trained in the 80s, we almost never saw it, 1 in 2,500. The most common quoted rate now is about 1 in 500, but there's some more recent epidemiologic data that suggests that it's as often as 1 in 300. And we see these probably 1 a month at St. Vincent's, I would guess. So they're not infrequent at all. Now, obviously, they're concentrated there because that's where a lot of the support is. And PPMC does a fair amount of them too. So Specifically related to the risk factors, like I said, about 1 in 500, we see it in pregnancy. Just having prior cesarean sections increases a risk. And when you have 2 or 3, it is associated with about 1 in 200 incidents. The placenta previa, these are the numbers you read. I certainly don't see it this frequently, but as many as 1 in 20 previas are reported to have a placenta accreta. Now, the money is where you have multiple cesarean sections and a previa, and with 1, the incidence is about 10%, and it increases from there. And when you have 3 or more often than not, you're going to have an accreta. And I told you about the endometrial ablation. Although it's rare that you will see these patients pregnant, when they do, there's a very high risk of placenta accreta. So what are we looking for when we do the ultrasound? There are a number of factors. The more of these you have, the more predictive it is going to be. But individually, they're not always predictive on their own. Placenta lakes you hear a lot about. In and of themselves, they're a benign finding, but when they're associated with other things or patients with risk factors, then you need to start thinking about accreta. And those are by far and away the most common finding in a patient with accreta. You hear about loss of that clear zone or loss of Nittenbach's layer, and that's fairly common. It's also kind of subjective, so it's hard to, there is some variation when people start looking at that. And then from there, myometrial thinning or bladder wall interruption, those things are associated with placenta accreta. The bladder wall interruption, though, we used to think would predict per accreta, but it just isn't very good at that. And I'll show you some of that data here in a minute. And then the placental bulge, it just looks like the placenta is bulging through the myometrium and into the, up against or into the bladder. Color Doppler, we see lots of vessels. They light up like a Christmas tree, and it goes from just a line along the margin between the uterus and the placenta, and it actually crosses that margin. Those things are much less common. And again, I want to emphasize the fact that we're okay at detecting placenta accreta. We're not good at all at detecting the depth of invasion. So here is just a classic image of a placenta accreta. Here are the placenta lakes. They're big, they're ugly. Here is the bladder up here. And what you see is you see some gaps in this myometrial interface. Here's shadowing, so this is an area that we can't see very well, and the cervix is going to be down here. It just isn't caught in this picture, but these are things that are very concerning, and this patient actually had an accreta. So how good are we at determining whether we have an accreta or not? The literature would suggest that the sensitivities are around 90%, but part of that is ascertainment bias, meaning that we are good because we know that these patients already are at very high risk. So without us, we're going to be pretty good anyway. So in this study, they blinded ultrasonographers, radiologists, actually MFMs, and they took 55 patients who had an accreta and 55 who had a previa without an accreta, and they asked them to diagnose it. And so the sensitivity and the specificity are not very good. They identified just under 2/3 of them, and a specificity where it shouldn't be that high. 87% is not very high for a specificity, meaning that when the disease is not there, you say that the disease is not there. The positive predictive value is good at 82, and the negative predictive value, that should be very high, and it's poor. And the accuracy is about 75%. And the accuracy simply means that what you say is there is there, either an accreta or not an accreta. And those were only when they were certain of the diagnosis. When they weren't certain and you took all of the interventions, the performance was less for the sensitivity, no different for the specificity, and the accuracy was decreased. So, well, if there is some limitations to it, can we at least agree on what we're seeing? And the answer is sort of. The ultrasound, in this same study, what they did is they found that the sensitivity was ranged between about 50% up to 75%, the specificity between 70 and 95. The accuracy actually was pretty close. And the reason for that is, as you look at the sensitivity, those that were more inclined to call it a Accreta actually called a lot of normal ones Accreta too, and vice versa. If you were more looking to call it not an Accreta, you were more likely to have the higher specificity. And that's just the traditional trade-off that comes with sensitivity and specificity. So what about MRI? Well, we often get that, and we get that because we believe it will help us. And in this study, what they did is they already had a bias sample because they had patients who either had ultrasound suggestive of an Accreta or they had very high risk factors, and they all had ultrasounds done, and then they went on to MRI. So the MRI is only dealing with those that are already at high risk, and then they classified it as no Accreta, Accreta, or a per-Accreta. And then what they did is all of those patients had an MRI, and they classified it the same. So in 2/3 of the cases, the MRI confirmed the ultrasound diagnosis. And in about 2/3 of those, the confirmed diagnosis was the correct thing, meaning there wasn't an Accreta or there wasn't an Accreta, and that's what ultrasound had said. In another 1/3 of them, though, the incorrect diagnosis was confirmed, meaning that the ultrasound said the wrong thing and the MRI said, yep, that's it. And so it wasn't right either way. And when you take the other ones where the MRI changed the diagnosis, what happens is you could flip a coin. Half the time it got it right, half the time it took a correct ultrasound diagnosis and made it wrong. So the MRI is not very helpful. And the next question, well, can it help us detect a Accreta? And these numbers are really hard to get at because they're already mixed up with other things. But the ultrasound sensitivity was a little bit less than MRI, but with the numbers, it wasn't statistically significantly different. And not surprisingly, the ultrasound had a better positive predictive value. So if you said it's there, it's more likely to be there, but still a quarter of the time it isn't. So just kind of to finish up, these stents and the iliac balloon catheters, these are questions I get a lot. Well, should we do these things? And the answer is there isn't good data for either of them. The stents don't seem to cause much harm. It does add time to the pre-procedure. And whether it makes a difference or not isn't very clear. So that is recommended that it's up to the surgeon to decide whether they want them or not. You're going to have to dissect out the ureters anyway, so just trying to palpate for the stents isn't going to be enough. But the iliac catheters should not be used. There's no evidence that it decreases blood loss. The studies are conflicting, and there certainly are complications. There's damage to the arteries. They can get in and occlude and not be able to be deflated. There's an infection risk because they typically go through the groin, and also they sometimes can't come out and they have to be retrieved. So they don't help and shouldn't be used. And, oh, I forgot about this. Don't forget to call your MFMs. No, the code word today is don't forget. And just to finish up.
It was for your final thoughts.
Oh. Got it. Well, the final thoughts are just that this is an increasing problem. We are seeing it more and more, and because it's so morbid, we're concerned about it. The majority of these occur in patients who have a prior cesarean section and a previa. So regardless of what else is going on, be prepared in those patients. And they probably ought to be referred to a place that can handle them. The ultrasound can further increase the risk or characterize that risk, but you still need to be prepared because it misses them on occasion. The imaging won't help you determine the depth of invasion, so you have to be prepared for what you saw at the beginning. And the MRI adds little, so it shouldn't be routinely done. There are cases where you might think it'd be helpful, and that's okay, but it should not be routine.